Okay, so let's move on to different types of skin cancers. So, so skin cancers are abnormal growth uh, of skin, right? So, and typically, any of them develop due to exposure to UV light, right? The sun. So you're at higher risk for developing skin cancer if you're in the sun frequently. So construction workers, people that work in the fields, they're out all day, they're at higher risk for different types of skin cancer, or just laying in the sun. And of course, if you've had recurrent sunburns, well, that's damaged the skin multiple times, and that can lead to skin cancer later in life. Okay, so there are precancerous skin lesions that are called actinic keratosis, and these often appear on sun-exposed areas of the skin, so ears, nose, face, hands, and they're typically rough, small, rough areas that are that have peeling skin. They almost feel like sandpaper when you rub them. Okay, and they're the result of UV sun damage. Okay, so they're not cancerous yet; they're precancerous. So if left over the span of years, they will become cancerous. So what are the three types of skin cancers? Well, there's basal cell cancers, there's squamous cell cancers, and there's melanoma. Basal cell is definitely the most common type of skin cancer, and it's typically the least dangerous because it just tends to grow locally. Okay, and we'll have some images of skin cancers, but basal cell skin cancer, sorry, doesn't metastasize. It just grows locally. Um, Squamous cell carcinoma um, also grows in sun-exposed areas of the skin in particular, and this one has potential to spread. Okay, so it's a higher risk skin cancer than a basal cell carcinoma because of its ability to spread. And lastly, a melanoma. Well, melanomas are definitely, while they're the least common, and they can often occur uh, from moles um, that we call dysplastic moles. So they're abnormally appearing moles, and we'll get into that. And um, they're also more common in sun-exposed areas of the body, but they can appear anywhere because they can grow out of or they can develop from a mole as well. So they're the least common, but definitely the most dangerous because they have the ability to spread to lymph nodes and, of course, metastasize throughout the body. Okay. So really the risk of skin cancer is significantly reduced by minimizing sun exposure. And skin cancer is on the rise in North America because we're out in the sun a lot, people sunbathe a lot, and that leads to skin damage. Okay, so really the key for any skin cancer in terms of uh, prevention of metastases, say of a squamous cell cancer or a melanoma, is early detection and removal. Okay, that would also go for a basal cell cancer, but remember, the basal cell cancers, they don't metastasize. Okay, so here are the three different skin cancers. So melanoma, which is typically pigmented, it can develop from a mole, as I mentioned before, um, and the highest potential to metastasize, and also uh, the most dangerous. Basal cell skin cancer, again, locally growing, locally invading, not metastasizing. And lastly, squamous cell skin cancer on the right there. And I have a better image of a basal cell skin cancer on an upcoming slide. Okay, so remember actinic keratoses, which are these just dry, scaly areas. So in this slide in the top left, you can see these dry, kind of inflamed red areas with a bit of flakiness on top. That's actinic keratosis. Okay, and they can lead to either basal cell or squamous cell cancers. Okay, and notice that these cancers in the bottom right, they're raised and then they have a bit of a crater to them in the middle. Okay, and that's pretty typical for a basal cell carcinoma. Okay, I've covered a lot of this already. So the three types: basal cell, squamous cell, and melanoma. Basal cell being the most common, um, definitely from long-term sun exposure over many years, and the sun-exposed areas of the skin, the head, the neck, the nose, the ears, the hands. Okay, so for example, if you're bald, well, the top of your head is a common area to get basal cell skin cancer because it's constantly getting sun exposure. Okay. Um, Slow growing locally, very rarely, if ever, metastasizes. So really just think of it as a locally growing skin cancer. Squamous cell, again, sun exposed areas because of that UV radiation, and also has the potential to metastasize either to lymph nodes or to distant areas of the body. Okay, so we're gonna come to melanoma in a minute, but let's just talk about moles for a minute, or nevi. So a normal mole is typically just a small brown pigmented area of the skin, right? And it has a very distinct edge to it. So nice rounded edge. It's not bleeding, it's not itchy, it's not irritated, um, and and moles are extremely common, right? What's a dysplastic mole? So a dysplastic mole is typically a larger mole, and it doesn't have that nice round oval shape anymore. The edges of it don't have a nice circular edge. They can have rougher edging to them. They can be mixed in color, so it might be a bit of brown, a bit of black. Um, they can also bleed. Okay, so any mole that bleeds is concerning. Okay, because that may mean that there's melanoma developing within the mole. Okay, so dysplastic moles are definitely a risk factor for developing melanoma. And some patients or some people have um, what's called a dysplastic mole syndrome, where they have many, many dysplastic moles, and they need very close monitoring. And often they go to a dermatologist and they have photos taken of their skin, and they have regular follow-ups to make sure that none of the moles are changing in shape or they're starting to look more and more irregular. And if they are, they get removed. Okay? So whether it's a change in shape or a change in color or the change in size or bleeding of a mole or a dysplastic mole, that would be a reason for the mole to be removed. Okay, so when would we suspect a skin cancer in the setting of a mole? So we're referring more to melanoma here. So say you have someone who has moles, and when would we suspect that there's potential for the mole to have melanoma within it? Well, if the mole has asymmetry, okay? So it's not a nice circular mole. One side is circular, the other side looks very asymmetrical and irregular. That's concerning. The border of the mole looks very ragged and notched. Okay, so it's not a nice clear round border. The color, so multiple shades of brown and black within the mole, is again a concerning feature that this is either a dysplastic mole or it has melanoma. The diameter, so the larger a mole gets, the more concerning it would be. So 6 millimeters, so over half a centimeter, that's getting larger, right? So they're at higher risk of developing either dysplastic mole or melanoma. And finally, an evolving mole. So it's changing shape. Say it was the same for years and now it's changing shape or size, or the color. And of course, lastly, bleeding. Okay, those are all concerning features that would need follow-up and potentially removal of the mole. Okay, and here's some examples of melanoma, right? And what actually determines the the degree or the concerning aspect of a melanoma? I mean, they're all concerning, right? But there's some that are very superficial. They're less concerning. They still need treatment for sure. But the deeper the melanoma goes into the dermis, the much more higher potential it has for having spread already. Okay, so if you look at the top left, you'll see that there's a nodule with that melanoma, and it's likely grown inwards as well. And the deeper a melanoma goes into the skin, the higher the risk is for it to have already metastasized to other areas of the body. Okay. Okay, so malignant melanoma, they can certainly grow rapidly. I mentioned that it's the depth of the melanoma that matters the most in terms of its prognosis, meaning, okay, the deeper the melanoma is in the skin, the more likely it has spread to distant areas, okay? And it can metastasize to any organ. The vast majority of melanomas are in sun-exposed areas of the body. That's not always the case, but that's by far the most common areas. So really, early detection is key for melanoma because the longer it grows, the more likely that it's grown to a deeper level into the skin and it's metastasized. So if we suspect someone has a dysplastic mole or a melanoma, it'll be typically removed in total with a very wide resection around the melanoma. We won't just cut out the one area that looks abnormal. If it's really felt to be melanoma, the whole area around, so even some normal skin around it will be removed to make sure that the entire cancer has been removed. And lastly, if it's melanoma, often the lymph nodes that drain that part of the body, wherever that melanoma is, the lymph nodes are sometimes biopsied to see if there's any cancer within the lymph nodes. Okay, so let's go away from skin cancers and talk a bit about fungal infections of the skin, which are very common. And when we're talking about superficial fungal infections of the skin, so fungal infections that do not go deep at all. So they don't involve organs such as the lung and the kidneys, they're just on the skin. We call those tinea, okay? And typically, they're an expanding circular rash, and that's why we call it ringworm. Okay, it has nothing to do with a worm. It just came about because it's an expanding ring on the skin, and I guess someone came up with the term ringworm. But usually we have to tell patients this has nothing to do with a worm. This is a fungal infection. Okay, and often they're scaly, they're itchy, they're a bit irritated. And where does tinea like to grow? Nice, warm, moist areas. So between your toes, in the groin, especially in the summertime. Under the breasts, where there's two layers of tissue touching each other, right? So whether it's in the groin or under the breasts or under the armpits, nice warm areas that are moist. And usually, tinea is treated with antifungal creams, and that typically clears up the tinea infection. Candida, similar to tinea, is a yeast infection, okay? And also typically likes warm, moist areas, okay? So it can grow in the back of the mouth. So when would we get tinea in the back of the mouth? When would we get candida in the back of the mouth? So thrush. Well, children get it frequently. Adults get it if they're, say, for example, on antibiotics, or they're using a cortisone inhaler for asthma or COPD, because the cortisone locally suppresses the immune system in the back of the mouth, and candida can then grow. That's why we ask patients to rinse their mouth after using cortisone inhalers. Okay? Vaginal candidiasis is very common, especially if a woman is having to take an antibiotic. There's a much higher risk of getting candidal yeast infections or even oral thrush while on an antibiotic. Okay? Children get it in the diaper area. It's a nice, warm, moist area, and candida can easily grow there. Okay? And we would call that diaper dermatitis or diaper candidiasis, one of those terms. Okay, so antibiotics. Diabetics are more prone to getting candidal infections because diabetics have a bit of immunosuppression. Just by having diabetes, you're a bit immunosuppressed. Okay. Pregnancy, you're more at risk for getting candida. Why? Well, pregnancy is actually, you're a bit immunosuppressed as well. You have a fetus that has antigens that aren't the same as yours. So the body is tolerating the growth of a fetus that has different antigens. So we consider pregnancy a bit of an immunosuppressed state, and they're slightly at higher risk for developing candida, in particular vaginal candidiasis. Definitely immunosuppressed patients, patients that are on chemotherapy, patients that are HIV positive or have AIDS, they often develop oral thrush. Okay, so in the back of the mouth or the vagina, it's typically in the back of the mouth. It actually looks like milk curds back there stuck on the pharynx. In the vagina, women often come in and say, I have a white, kind of a cheesy discharge, and they're typically very itchy and irritated. Okay? So tinea, as I mentioned, is a superficial fungal infection, and it's just defined on where in the body it is. So tinea crus is basically jock itch, right? So it's tinea of the groin, tinea crus. Tinea corporis is tinea of the body. So you can imagine someone who works as a construction worker and they're sweating all day outside, a nice warm moist area, and they come in with tinea corporis, or the other term, ringworm, which isn't terribly accurate. Tinea pedis, again, if you're in shoes or boots all day, like many people are in boots, and they're sweating and their socks are wet, they can develop tinea pedis either between their toes if it's mild, or in this image you can see that the tinea pedis is really throughout the whole foot, right? And we actually call that, not that you really need to know it, but we call that moccasin foot, when there's so much tinea pedis that it almost looks like they're wearing a moccasin. Okay. I mentioned that these are usually easily treated with topical antifungals. Okay. So just remember, for tinea. They like nice, moist, warm areas such as the groin, under the breasts, the armpits, and of course the feet, because we're often in shoes and boots. So the main part of treatment is really making sure that the area is dry, and of course the antifungal medication. Okay, so here's just some examples of um, uh, uh, fungal or yeast infections. So the top left oral candidiasis, so that's yeast at the back of the throat. Again, very common in women, very common in children, sorry. And people can develop if they're immunosuppressed, such as HIV or on chemotherapy, and as well on a cortisone inhaler. Bottom left, for oral candidiasis, also antibiotics can cause oral candidiasis. Vaginal candidiasis, typically, again, from having taken oral antibiotics, not always, but often it's from having taken oral antibiotics that's changed the normal flora of the vagina, leading to overgrowth of candida. Okay, and they, as I said, come in itchy, irritated with white vaginal discharge. Top right is an image of tinea pedis, right? So you can see the scaling skin, and that's from the fungal infection. And none of these go deep into the body, okay? These are all superficial. The only exception to that would be oral candidiasis. If someone's really immunosuppressed or has HIV, sometimes the oral candidiasis can actually spread down the esophagus and cause tremendous esophagitis. Okay, so they come in not only with oral thrush, but they also say, I have difficulty swallowing. It's very painful to swallow. And that often means that the candidiasis has spread to the esophagus. Lastly, onychomycosis is a fungal infection of the nail matrix, right? So the nail itself is infected with a fungus. It typically doesn't go anywhere else, but it does cause local destruction of the nail itself. And if you recall, nails take about 3 months to grow out. So if the patient really wants this to be treated, they can either take an oral medication for 3 months, an antifungal, or there's now topical antifungals that you can put directly on the nail for 3 months, waiting for the new nail to grow out. Okay, let's talk about some viral skin infections. So warts, very common. So it's the human papillomavirus that causes verruca vulgaris. These names are always interesting to me. Verruca vulgaris is a wart, and it's skin growth caused by HPV, right? And there's many different strains of HPV. So the virus typically spreads through direct contact, so tiny cracks or breaks in the skin that allows the virus to enter into the cells of the skin. Okay, remember, HPV is also responsible for cervical dysplasia and cervical cancers. Okay, so HPV can actually be, you can actually get genital warts, which puts women at risk for cervical dysplasia and cervical cancer. And that's why there's an HPV vaccine available to try and prevent the development of cervical cancer in women. Okay? Now, if you were to leave a typical wart that's on your skin, your hand, or your foot, most of them will just resolve spontaneously, but it can take many years for them to resolve. So some patients don't really want to have warts for years. Okay, but the natural history of a wart is that it will disappear if it's on the skin. Okay, most warts are spread by skin contact or through sharing of um, towels, or washcloths. Children and young adults or immunocompromised patients are typically the patients where you see the majority of warts. But warts can occur basically on anyone. Okay. Remember, I did mention HPV as also a sexually transmitted virus that can lead to warts on the penis uh, or genital warts. And of course, it can cause dysplastic changes on the cervix in women that can lead to cervical cancer. Okay? And how do we screen for cervical dysplasia? Well, with a pap test. And that's why women go regularly for pap tests. Okay? And of course, now we have a vaccination that's given in childhood to try and prevent um, genital warts that can lead to cervical dysplasia and cancers. Okay, and these are just all images of warts, right? So on the face, on the hand, that's a lot of warts on the hand, by the way, but it can happen. Sometimes there's just one, sometimes there's multiple. And of course, on the sole of the foot, another common place to get warts, and we would call those plantar warts when they're on the sole of the foot.